We're good to go? Okay, so good afternoon, and it's good to see you back again, some of you who were with us in the working group. We have a couple of hours, but we have also a very packed agenda. We have over 150 slides, so just gives you an idea of how much information we have to provide you. Again, thank you for joining us, and also I'd like to thank all the people who are joining us from remotely. On behalf of Dr. Fiora and myself, we'd like to start the meeting. And before we go into the presentations, I really want to quickly introduce a number of people to you. So in addition to the two of us, I'd like to thank Dr. Christopher Ryan, who is our executive officer. And then the Gastrointestinal Committee, these are the members. Dr. Washington, who is a pathologist from Vanderbilt, Dr. Heinz Joseph Lenz, who you know very well from ESC, Dr. Christopher Liu, who is from Colorado. I don't know if he's here yet. Dr. Berman, surgical oncologist from Baptist Memorial Hospital Health. Dr. Saeed Ahmed, who also leads the GI Surgical Committee at SWOG. He's from University of Cincinnati. My colleague and friend for many years, Dr. Anthony Shields, who is an imaging expert, and he's our imaging go-to person in the committee from Karmanos Cancer Center. Lisa Kachnik, radiation oncologist from Columbia, but also she's on the executive committee of SWOG. And then cancer prevention liaison is Dr. Zell, cancer control liaison, Barzi, and Dr. Gary Burshak, who is the community liaison from Kaiser Permanente, and Dr. Mohammed Salim, again, one of my colleagues. He's a community liaison. He's currently at the Levine Cancer Center. Dr. Horowitz, a radiation oncologist from Columbia. He's also a community liaison. Dr. Chan Shen, she's from Penn State College of Medicine, and she's a community liaison, as are doctors O'Rourke from NCORP in the Carolinas, NCORP, and Dr. Lee Devine, a surgical oncologist from Tennessee. We also have Dr. Sandeep Patel for phase 1 drug development, Dr. Flavia Rocha, a surgical oncologist, and he's a surgical community liaison, and he does a lot of our interactions with the surgical world. Dr. Heloisa Suarez, the digital engagement. Dr. Jane Rogers, pharmaceutical science liaison from MD Anderson, and Dr. Jason Reed from, again, pharmaceutical science liaison from MD Anderson. The committee cannot really do its work without our invaluable help we get from Catherine Guthrie, our biostatistician. Dr. Guthrie has been involved with a lot of the work. You will see, in fact, all of it. She's helped by Ms. Sarah Colby, statistician, and our committee is really run in terms of the coordination by Christy Kleptiko, who could not make it today. We also have other people who are crucial for the work we do. Ms. Sandy Annis, Mr. Simon Gurung, Ms. Christine Magner, Ms. Jacqueline Skurlock, and Mr. Brian Zeller. The whole meeting you see here, the 3 floors of the Hyatt Regency, is being coordinated, and a lot of the work done by Courtney Willie, who's been very helpful with us and very patient also. So this is the agenda for today, and what we're going to do is start with some featured clinical trials that we'd like the community to be aware of. And with each of these studies, we also like to know your input in terms of what do you think about the study in terms of accrual? How do you feel about opening the trial if you haven't done it yet? And if you've opened it, if you have any concerns or problems or difficulties with the clinical trial. So just to remember that you can ask questions from here, from the podium, and for those of you who are joining remotely, then you can use the chat room, and we'll be regularly following up and looking at the questions. With that, I'd like to invite to the podium Dr. Heloisa Suarez okay, sorry, something which we put Okay, yeah, that's my fault. Something which we added to the agenda, which I'd like Dr. Karian to talk about. This is something about really goes into clinical trials and how we can do better, taking the aspect of having more patients and being more diverse.
Before I talk about diversity, talking about physicians and patients alike, I just wanted to let everybody know who is going to present remotely. You will need to ask for us to advance the slides for you, so that's just for you to know. And for those that are present here and they are presenting their slides, we're going to invite them to quickly jump up on the podium. So you have to be fast and anticipate that coming up so that we can keep moving. So I just wanted to bring up, we talk about diversity and equity and inclusion a lot. And oftentimes we think about our dear patients, but we also have to think about ourselves and about our junior investigators, about women in oncology, about including radiation oncologists and surgeons in our trials. So equity goes for all of us. And this is a paper that Philip actually drew my attention towards, just recently published in JCO, which points out that actually eligibility criteria in our clinical trials make a lot of difference in whether we are able to or not to enroll a diverse population. And I do want to bring this to your attention. In general, from a study done in Virginia, at Virginia Commonwealth, in pancreatic cancer specifically, you can see here in blue, in the Black population, and in red in the white population, that there is extreme diversity even in albumin levels, in kidney function, etc. So in fact, improving our eligibility thresholds, eliminating those requirements that the patient cannot have hepatitis B or hepatitis C or HIV, allowing a creatinine clearance more than 30 rather than a certain creatinine level, allowing an albumin of 3 rather than 3.5 can actually equalize the likelihood of us enrolling Black and white patients alike in our clinical trials. And another paper that drew my attention, recently published in JAMA Network, showed that many women that are investigators in phase 3 clinical trials don't make it as a first or senior author. There is a higher proportion of women investigators and a clear lower number of women who are actually leading the study or being a senior author. And gastrointestinal oncology, you'll see it in the table, has about 16% of committee members for GI oncology trials and about 14 to 20% representation as a first or senior author, among the lowest. And of course, one of the best is breast. Another aspect is surgeons. Surgeons are brilliant, and especially the surgeons in the GI committee. And we think that, in fact, surgeons have a huge contribution in clinical trials. And as you can imagine, it's the type of trials that are multidisciplinary, that are conducted through our cooperative groups, where we need surgeons and equally so radiation oncologists. And this is a paper published by Rebecca Snyder and Syed Ahmad and Matthew Katz that again points out to how capable and important the contribution from surgical oncology is. So thank you so much for allowing me to speak to that. And now about feature studies. Heloisa? And remember, we have to be fast.
All right, everyone, Eloisa Suarez from Huntsman. I just wanted to highlight this study that's very close to my heart and thank all of the involved parts, particularly the folks from the surgical committee, Doctors Matt Seid and Flavio Roca, who really help us to develop this study. So this is a study to address the role of adjuvant treatment in patients that had resected well-differentiated pancreatic neuroendocrine tumors that are grade 2 or 3 with a KX67 up to 55%. And this is important because we debate in clinic all the time what to do with these patients that we know that have high-risk features for recurrence, whether or not there is any role for any adjuvant treatment. And extrapolating from the data from the ECOL 2211, we're using as our adjuvant strategy capecitabine and temozolomide. So patients that are high risk for recurrence after the resection will be randomized on a 2-to-1 fashion to receive CAP10 for 4 months versus observation. Patients that had metastatic disease, but localized in the liver only and up to 5 lesions that had been fully resected or ablated at the time of surgery will also be eligible for this study. Our endpoint is 3 years recurrence-free survival. And what is good about the study, and we really want to encourage the community to consider, is that patients will be allowed to have some telehealth visits, particularly in the beginning, if they were randomized to the observation arm and need to have visits with the physician just for the sake of balance that can be done through telehealth. The CAP10 is going to be considered standard of care and had been validated through a Medicare cost analysis. So if you ask me what is the high-risk features, if you go to the next slide, please. So these are the Zaidi score that has been validated to assess which patients are high risk. And anyone that has a score of 3 or more is considered to have a risk for recurrence. Typically, it's a tumor that has a size that's more than 2 centimeters, or positive lymph nodes, or a KX67 that's 3% and above. And I'll stop here. And if anyone has any questions, I'll be happy to answer them.
Thank you. Thank you very much, Louisa. How many people have not opened the trial in their institutions, and why? Okay. Tell us why you didn't open it. Use the microphone, please.
Mainly because it's a rare tumor, and our clinical trials office is very hesitant to open trials which are low accruers due to cost and time and effort involved. So it doesn't pass through the committees.
Okay, so that may be a reason many people will not be opening the trial also. Okay.
Right. Refer to one of the centers that have the trial. Remember, telehealth is allowed.
So how do we answer a question in a situation where there's no standard of care? I mean, that's why we do it through SWOG, many institutions, and even if you put one patient a year, it really contributes to the science. So, okay, thank you.
Van, you are presenting remotely. Please do ask for us to advance the slides.
Great. Yeah, so thank you so much for the opportunity to present on the next slide here. This is the SWOG 2107 trial. It's the trial looking at encorafenib cetuximab with or without nivolumab for patients with microsatellite stable BRAF V600E metastatic colorectal cancer. So on the next slide, we have some rationale. We know that BRAF mutations, patients with microsatellite stable BRAF mutations account for approximately 5% of all patients with metastatic colorectal cancer. So probably even a more sizable population in terms of sheer numbers than those with MSI high metastatic colorectal cancer. We know that this is a poor prognostic implication when a patient has a BRAF V600E mutation. And despite the recent approval of encorafenib and cetuximab for this indication, the overall response rate with the doublet, the BRAF EGFR doublet, was only 20%. The median progression-free survival, as you can see in the figure on the right here from the phase 3 trial, was just 4 months. So we've made some strides, but still a lot of room to do better for these patients. And there's reason to think that biologically that the MSS BRAF V600E population may be more immunologically active than their MSS BRAF wild type counterparts. And in some really interesting work that was published in Science 3 years ago from an Italian group, they showed that in an MSS BRAF V600E colorectal cell line, when you treat these cells with a BRAF EGFR directed therapies, you flip the status from a proficient to a deficient mismatch repair, which kind of begs the question, could we potentially prime these MSS BRAF V600E colorectal tumors to response to immunotherapy by treatment with the BRAF EGFR combination? So we looked at that at MD Anderson in a trial of encorafenib, cetuximab, and the anti-PD-1 antibody nivolumab, specifically in patients with microsatellite stable BRAF V600E metastatic colorectal cancer. And as you can see on the next slide, in data that we reported at GI ASCO earlier this year, the response rate was overall, fairly promising in the first 22 patients that we looked at. 11 patients had a response, so an overall response rate of 50%, a disease control rate of 96%. Only one patient had progressive disease straight out of the gate. The median progression-free survival that we saw in our initial cohort as well was 7.4 months. So again, this comes with the limitations and interpretation of being a single institution study at MD Anderson. But when you keep in mind that the median PFS, again, with encorafenib, cetuximab was just 4 months, the overall response rate was 20%. The signal here is very intriguing and consistent with other data from MGH looking at a MAP kinase PD-1 combination as well, which reported similar promising results. So, while these results certainly are exciting, it really begs the need for a more formal look into this question of what the benefit of adding anti-PD-1 therapy is. And so that's what we're doing with SWOG 2107, looking at patients with microsatellite stable BRAF V600E metastatic colorectal cancer. Patients will be randomized in a 2-to-1 fashion to encorafenib, cetux, and nivolumab, or encorafenib and cetuximab. So there's a 2/3 chance in this trial of 75 participants, a 2/3 chance that people will get to have the immunotherapy added to standard of care. We did get approval from CTEP for the protocol last month, and just yesterday the protocol was reviewed at the central IRB. So we expect, hopefully that this trial will activate if things continue to move smoothly. Around the time of ASCO with a drop dead kind of deadline from CTEP by July. So in the next coming months, look for this trial to open. On the next slide, just kind of brief eligibility criteria, specifically patients with MSS, BRAF V600E metastatic colorectal cancer who have had 1 or 2 prior lines of therapy, an ECOG performance status of 0 or 1, and adequate kind of kidney, liver, hematopoietic function as well. Patients are not allowed to have had prior BRAF inhibitors, anti-EGFR therapies, or immunotherapy, must be naive from all of those. So really excited about, moving this trial and leading it through SWOG. And certainly SWOG has a track record with the 1406 study, which ultimately led to the BRAF EGFR development as well. So continuing that strong tradition with SWOG here. Thank you.
Thank you so much, Van. In fact, Anthony El-Khoury will present next the next study, 2109.
Any questions for Dr. Van? Okay.
Anthony?
Okay, thank you. This next trial is focused on hepatocellular carcinoma, and this builds on 2 important facts. One, the activity of dual PD-1 and CTLA-4 inhibition in advanced HCC, showing good promise across lines of therapy. Specifically with nivo-ipi, we know that post-sorafenib, there was a response rate of 30%, median overall survival of 22 months. And we know from Dr. Ahmed Kassab's data at MD Anderson, where he looked at nivo versus nivo-ipi in a small pilot trial, and saw a very promising pathologic response rate of 25 to 30%. we decided to take this forward into a multi-institutional setting through SWOG with a randomized phase 2 study of neoadjuvant nivo-ipi versus going straight to surgical resection in patients with resectable HCC who have well-preserved liver function naturally and Child-Pugh-A. Primary endpoint would be event-free survival. And there is a clear definition of what an event is that includes both progression or failure to reach resection, as well as recurrence post-resection. And you see the secondary endpoints. There's a lot of exploratory endpoints related to biomarkers. We are aiming for a hazard ratio of 1.52 with a median recurrence-free survival for the experimental arm of 50 months. Which would require the enrollment of 180 patients total. It's 86 per arm, with some patients who will not be evaluable, of course, built into the design. This study has received the GI Steering Committee approval and CTAP approval, but we are still in discussions with BMS because they have to give their final approval to support the study with drugs through the CRADA, through CTAP, and that's not finalized, unfortunately, at the moment. This is the intervention, how it's built. The therapy would be for about 10 weeks, with surgery occurring between weeks 12 and 14. The ipilimumab will be dosed at 1 milligram per kilogram to minimize toxicity, and the patients will receive 2 doses of epi at week 0 and week 6. And then nivo will be every 2 weeks. And the safety of this regimen has already been shown in the pilot study by Dr. Kasab. That's it for this presentation. If there are any questions, happy to address them.
Thank you, Anthony. A great presentation. And if any questions? Okay. Well, thank you again. So,
yeah, hi. So this is Vincent Chung. I'm from City of Hope. And
Vince, can you hold on a second? There's a question for Anthony. Anthony, there's a question for you.
Yeah, Magid Khalil from Lehigh Valley, Pennsylvania. I want to ask, what is the percentage of patients with Child-Pugh-A that will not qualify for transplant and would qualify for this study?
Yeah, that's certainly the population of resectable patients in the US is certainly smaller than in Asia. That's what you're getting at. In theory, patients should only go to transplant if they're not resection candidates. That's in theory the rule. But the study is designed really for patients with either solitary tumors, or if they have more than one tumor, a maximum of 3 in the same lobe. So it has some criteria related to the number of tumors as well. As far as giving you a percentage, I don't know that I have that, but we've done a feasibility review at large volume centers, looking at how many resections they have per year. And that's how we came up with the estimate that this study would be feasible to be completed in 2 to 3 years if it opens throughout the network.
Okay. Does that answer your question? Thank you. Thanks again, Anthony. And then Vince, Dr. Chung.
Okay, great. Thank you. Yeah, so I'm Vincent Chung. I'm actually the study chair for S2001. Mike Pishvayan at Johns Hopkins is my Alliance co-chair. So this is a randomized phase 2 study of olaparib versus olaparib plus pembrolizumab as maintenance therapy in germline BRCA1 and BRCA2 mutated pancreatic cancer. And this is really building upon the positive results of the POLO trial, which showed that after a minimum of 16 weeks of platinum-based chemotherapy for germline BRCA1 and BRCA2 mutated cancers, that Lynparza nearly doubled progression-free survival compared to placebo. The background behind this is that PARP inhibitors increase PD-L1 expression, also potentially activates the STING pathway. And we do know that patients that have deleterious mutations in the BRCA gene have increased genomic instability, thus making them more susceptible to immune checkpoint inhibitors. So for this study, one of the challenges that we face is that all patients, when they're first diagnosed with pancreatic cancer, need to undergo germline testing. That way you'll know if they are BRCA1 or BRCA2 mutated. This has to be done in SWOG because this is a rare population. Only about 5 to 7% of all pancreatic cancer cases are germline mutated. So I need all of your help in terms of being able to look for these patients. In the original POLO trial, they had to actually screen over 3,000 patients in order to get the 154. So your help is greatly needed on this trial. So once you know that they're BRCA mutated, then platinum-based chemotherapy is the standard of care. We actually did take your suggestions at the last meeting to heart, and we actually amended the study. So in January, we have a new amended study that allows 1 cycle of gemcitabine and nab-paclitaxel to be given. So if you start your patient on gemcitabine, nab-paclitaxel, and you get the results of their BRCA status during that first cycle, then you can always add platinum afterwards, and they would still qualify for this clinical trial. We currently have 9 out of 88 patients accrued so far. So I would like to, get your input in terms of what some of the challenges you're seeing. Have you had any issues with actually, doing the germline testing, and any other suggestions that you may have in terms of trying to increase accrual?
We have a question for you, Vincent.
Just a comment. This is Tony Shields from Kermanos. You should point out that they don't have to get FOLFIRINOX. I have one patient on the study, and I did not think she was a FOLFIRINOX candidate. And when I saw that she was BRCA positive, I gave her FOLFOX. So, just be aware that, I think a platinum clearly makes sense, but it doesn't have to be FOLFIRINOX to go on study. And she's doing well, by the way.
Yeah, that's a great point. Definitely, it can be FOLFIRINOX, FOLFOX, gemcitabine, cisplatin, and there are some people that are giving gemcitabine, nab-paclitaxel, and cisplatin. So it could be any of those platinum-containing regimens.
Okay, that's a good point. Thank you, Vincent. Question. Can you use the microphone, please?
Sorry, Carol and I were talking, and we just wanted to know, to help Vincent out, number one, on behalf of the GI Steering Committee, we obviously want these trials completed, right? And so what can we do to help, I guess, improve education for the community centers and other individuals so they can help with enrollment? Carol and I were wondering, is PanCan involved, and what else can we do?
So I can make a comment. To our great surprise, I hope I'm wrong, PanCan doesn't have it on their list. And I don't know why. I hope I'm wrong, because that's what I heard yesterday.
It might be a help. The National Pancreas Foundation is certifying cancer centers around the country that can care for pancreatic cancer patients. So that list might be a big help.
Yeah, but PanCan is, as you know, the advocacy group. Patients call them when they're diagnosed. They get advice, they get second opinion, third opinion through PanCan. And PanCan can direct patients to clinical trials, but they have other clinical trials. Why they don't have this one, I don't know. It's easy. I'm on their board. I'm scientific. I know.
We already emailed PanCan earlier today, Kathy. So.
It was just surprising that it hasn't been there.
We also hear that some institutions that were that had opened the study, they decided to suspend it, maybe due to the poor accrual of these types of patients. And our goal is to really enrich the patient population to the somatics and the PALB2s, and maybe having a pharmaceutical company provide olaparib, since it's only approved for the germline patients.
Yeah, we don't have that amendment yet.
Thank you so much, Vince. Next, Dr. Zen.
Yes, thank you. So here I'm proud to introduce SWOG S2012, which is a randomized phase 2/3 trial, first-line platinum etoposide and with or without atezolizumab in poorly differentiated extrapulmonary small cell neuroendocrine carcinomas. So as many of you know, for extrapulmonary small cell cancers, these are patients with very poor prognosis, with a median overall survival of less than 1 year. Currently, our standard paradigm for the treatment of these patients is just like extensive stage small cell lung cancer with platinum etoposide. But building upon the data in extensive stage small cell lung cancer, where atezolizumab is currently approved with the combination of platinum etoposide, we're hoping to explore this in extrapulmonary small cells. So this is a group of patients that basically can be of anything outside of the lung. So this is GI, GU, GYN of any site. And essentially, these are all patients with neuroendocrine carcinoma, small cell histology, Ki-67 of 55% or greater. I've listed the eligibility criteria here, and our goal is really just to try to be as broad as possible for this patient population. We will allow up to 1 cycle of standard platinum etoposide, so understanding some patients do need to urgently start treatment, and stratification factors are listed there. So this is building upon the IMpower 133 study of platinum etoposide and atezolizumab. So we have a induction of 4 cycles of standard platinum etoposide followed by observation, that's the control. And then we have the experimental arm of atezolizumab and platinum etoposide, followed by up to 1 year of maintenance. Now you notice that in the middle, there's actually a red category where we're actually not giving the maintenance, we're just giving induction chemoimmunotherapy. And the rationale for that was in multiple discussions with the NCI, we wanted prospective data of what the role of maintenance therapy is. And so the primary endpoint here is overall survival. We're comparing each experimental arm against the control. And then we have a secondary endpoint of also looking at the overall survival of the maintenance phase. Next slide. That's what we'll do. So when this study was originally conceptualized, it was restricted to small cell primarily because there was a competing study run by Jennifer Eads and ECOG, EA2142, which was looking at high-grade GI neuroendocrine cancers. And this was looking at capecitabine and temozolomide versus platinum etoposide. Interestingly, in that trial, they excluded small cell histology, and so that's why this trial was made for small cell only. However, EA2142 has now closed to accrual, and so I've been in discussions with the NCI Neuroendocrine Task Force and also CTEP, and they have approved that we will go ahead and broaden the category, and so we will include all histologies, both small cell and large cell. Recognizing sometimes local pathology reports don't report out the histology, as long as patients have a diagnosis of high-grade neuroendocrine carcinoma and the Ki-67 of 5% greater, these patients will be eligible for this trial. So again, this is a rare patient population, but I will also say that these are patients often seen in the community and not necessarily seen in major centers. So like all the other trials that have been mentioned, any help that we can get to enroll patients on this study would be great.
So
Questions? We have a few.
I have a question to the audience. How are you using atezo in patients such as these? Like, are you getting off protocol? Are you successful? Are you doing it? Are you thinking about it? Or because that was one of the things which certainly challenged us when we were writing this protocol. Anyone want to? No, you don't use it as a.
We are not using it at our institution of the protocol.
Okay, good. All right. Question.
I have a question about 2 categories of patients. The extrapulmonary small cells or high-grade neuroendocrine tumors that are limited stage and could potentially be offered surgery or other modalities. Are they qualified?
Yeah, so it's not explicitly saying in the title, so these are advanced stages. So these are patients who have metastatic disease.
What about prostate cancer patients who advances from adenocarcinoma?
Correct. And so we actually had a lot of discussions that most of the prostate small cells arise in the setting of prior adenocarcinoma. So there's eligibility criteria of the adenocarcinoma component, but yes, those patients would be eligible. So, yeah.
Are the pancreatic neuroendocrine tumors included or excluded?
Yes, any site. So as long as it's outside of the lung, patients are eligible for this.
Because usually these patients are also treated with capecitabine and temozolomide, as opposed to platinum etoposide?
Yeah, I would say we used capecitabine temozolomide for the well-differentiated neuroendocrine tumors, but when it's poorly differentiated neuroendocrine carcinomas, we try to treat more with platinum etoposide. And obviously, more of the data from ECOG 2142 will be reported to see if the higher grades actually benefit from capecitabine or temozolomide. So.
Okay, thank you very much. We now move to NCTN studies and SWOG champions. I just want to say a couple of things about champions. One is that we were working very hard through the committee chairs to try to give more importance to the champions so that they can get some credit, publications, presentations, etc. So that's something we're working on, and I'm very much committed to that. The second thing is that the champions also, they have some responsibilities, and everything goes with some increase in responsibility and obligations. Champions have to also help us in terms of accrual of these studies. So an alliance trial and SWOG champion, the SWOG champion has to really work on through the community to help accrue to these trials. Because remember, SWOG also has to show that they put patients on trials. Doesn't have to be a SWOG trial, could be an alliance trial, but that's a number that we have. But also it gives the champions more engagement with the community and backwards and forwards with the study team. So with that in mind, we'll start with the champions. You're a champion.
I am definitely not a champion, but I speak on behalf of Dr. Stephen Berman, who couldn't be here with us today, to advocate for this perioperative pancreatic cancer study. This is led by Christina Ferroni, and it aims to study neoadjuvant FOLFIRINOX followed by surgery and adjuvant FOLFOX versus surgery followed by adjuvant FOLFIRINOX in resectable pancreas cancer. This study is accruing well, about 100 patients out of 300, and we're very thankful for everybody who participates. The next one is
maybe you can persuade.
Any questions on this study, on the alliance?
Any concerns about activating this trial? Again, it's a study that you need to get the buy-in of the local surgeon who does your surgical procedures. Doesn't seem to be any questions. Okay.
The next study is co-chaired by our own Anup Kasi at University of Kansas, an extremely prolific investigator. And this is going to study germline and somatic mutated pancreatic cancers with BRCA1, 2, and PALB2 mutations. After patients complete neoadjuvant, adjuvant therapy, surgery, and they're done, they will be randomized to receive olaparib versus a placebo for about a year. And this study is accruing, again, slowly, about 16 patients out of a planned 150. Any of you have this study open, and any questions about it?
So you can see this study includes PALB2 mutation also. The SWOG trial we talked about earlier doesn't include that, simply because that trial was written with strict criteria to follow the FDA approval, the phase 3 trial, POLO. And this is where it comes to these restraints on eligibility criteria that really ultimately affect us negatively.
And I see Anup, I see you online now. Any efforts or any difficulties in the community to activate this study, and anything you can tell us about it?
Yeah, hi, Gabby. So one is that, in terms of the germline testing, though it is part of the NCCN guidelines, I'm not sure if all the community centers are doing it. So we are trying to advocate for that. And the study does allow both somatic and germline. BRCA1, BRCA2, and PALB2 as we were discussing. So hopefully that helps. We are also going to have collaboration internationally. Israel is going to be participating in the study and other centers. So hopefully that helps pick up accrual. So far, I believe it was less than 15 centers that we have open so far. So hopefully in 2022, we'll have more centers. Bigger academic centers are opening this. And so hopefully we get more accrual. Of note, Invitae, they are able to offer free germline testing for pancreatic cancer patients through their, I think it's called the Cancer Detect program, though that particular program may be changing, morphing to a different one. But nevertheless, Invitae has that ability. So if cost is a barrier, then that is an option.
Okay, thanks. Dr. Shields?
One comment. I mean, this could be a just-in-time trial at your institution. If you, like we do, you regularly test these people early on when they're diagnosed. By the time they've had resection and finished adjuvant therapy, you've got a few months. So if you actually test them pretty quickly, you can say, hey, I've got a patient, I'm going to open the trial. You know, you don't have to just sort of open it and pray that you get somebody. You could get them and then open the trial. You've got the time.
That's a good point. I think that's a very good point. And it doesn't apply only to the study. I think it applies to other studies. That's a great point brought up. Okay.
Right. Yeah, that's a good point. Thank you, Dr. Shields. And as you can see, there is a pre-registration. So patients can be pre-registered anytime after surgery. And so that is that lead time for us to get the germline testing or somatic testing.
Thank you, Anup. We move now to the ECOL trial 2176, randomized phase 3 trial of immune checkpoint inhibition with chemotherapy in treatment-naive metastatic anal cancer patients. Dr. Morris is the champion, but if he's not online or available, I think Kathy can. She is the PI of the trial, so we're privileged to have her here. Just briefly, yeah.
Thanks, Philip. This is, looking at patients with newly diagnosed or untreated metastatic metastatic anal cancer. This is building on the prior INTERACT trial. Patients are randomized to either carbotaxol or carbotaxol with nivolumab. Again, a 2-to-1, a 2/3 chance that patients will have the opportunity to receive nivolumab in the frontline setting. So this trial is enrolling, fairly well so far early on. 45, so over a fifth of the way done with study enrollment thus far.
Okay, great. I think this trial should be doing well. Thank you. Okay, so next.
Can I ask a quick question?
Yeah, please.
Why does that trial exclude relapse after frontline chemo rats? What was the rationale for that?
Kathy.
It says that you're not allowed prior systemic therapy. Why? Oh, okay. So good to know.
Private, yeah. Okay, thanks. Now we have optimal perioperative therapy for incidental gallbladder cancer called OPTEN. It's a randomized phase 2/3 trial. Dr. Flavio Roja is our champion, but he may not be here.
He's actually chairing the surgery committee as we speak.
So basically, this study is about incidental gallbladder cancer, which is not an infrequent finding. And in those patients, they have to go back to oncologic surgery, as you all know. And basically, before they get the surgery, here idea is to see whether neoadjuvant chemotherapy with gemcitabine plus cisplatin, 4 cycles versus going straight to surgery really helps. But that's a trial. Now, this study is accruing slowly. I don't know if I have the numbers, but this study is struggling. That's the best way to describe it. And can we get any input to see why this is the case? It requires 180 or something, or 90 patients. Has anyone not opened this trial, or who has opened the trial in your institution? And can someone give an opinion on whether there is something which needs to be done to make it accrual faster? It's a rare population for sure.
I see Anthony online. Anthony, if you have any comments.
Yeah, I think as Flavio had mentioned earlier, this study really needs a lot of visibility with our surgical colleagues, because these patients with incidental gallbladder cancer, sometimes the initial surgery is done in the community, but then they're referred in after the cancer is found to a bigger center or an academic center. And at that point, that's when this patient would need to be caught for enrollment. So it really needs surgical leadership at the institutions where it's opening. Otherwise, it'll be very hard to recruit.
Thank you, Anthony. Okay, so we move forward now to the next trial, which is another ECOG study, phase 2/3 of perioperative nivolumab
And Saima will present.
and ipilimumab in patients with locoregional esophageal and gastroesophageal junction adenocarcinoma. Saima, you ready?
Yeah, so this is a study for Siewert's 1 or 2 adenocarcinoma patients with localized disease. Patients are randomized initially to standard of care carbotaxol with concurrent radiation versus carbotaxol plus nivolumab. They go on to surgery, and then after surgery, there's a randomization to standard of care nivolumab versus Nivo-Ipi. Actually, Gabby, can you go to the next slide and then the next slide?
Yeah.
So this trial is accruing well. Initially, go ahead, next slide, please. Initially, there was a little bit of a lag as they did a safety run-in. I think there's actually close to over 150 patients now. Target accrual in the first the first part here is 278 patients. SWOG accrual has been fairly low for this study. Next slide, please. There was a recent amendment which increased the adjuvant nivolumab to 1 year to meet the standard of care. It had previously been 6 months. And then to allow Q4-week nivolumab, change some of the other parameters, hematologic, and also the screening parameters afterwards to meet NCCN criteria. So the study is accruing, but within SWOG, there's been limited accrual.
Okay, thank you. Any questions?
Any barriers to opening this study? I wonder if people have competing institutional studies in this perioperative arena. I know we did at University of Washington. Okay.
Okay, so one more study which is not here. Can I ask Dr. Govindarajan to come and talk about the study you want to talk about? You can use the microphone, yeah. Just briefly, just maybe.
It's the ECOSOG study where we are using duloxetine for prevention of peripheral neuropathy for patients with stages 2 and 3 colorectal cancer.
And the study is run by who?
ECOSOG.
Who?
Sorry, Alliance.
Alliance, yeah.
I don't have the number.
Yeah, that's okay.
Yeah. This is a randomization between 30 and 60 milligrams of duloxetine versus placebo in patients who are receiving adjuvant chemotherapy with oxaliplatin. They should have at least minimum of 4 cycles of Kpox to up to 12 cycles of Folpox, mainly to assess the patient outcomes with peripheral neuropathy.
Okay, are they SWOG sites are open, do you know, or you don't? Okay. All right, thank you very much. So now we go into the actual subcommittees, and since Saima is online, so Saima, do you want to go ahead?
Actually, Zev is going to be presenting, Zev Weinberg.
I'm sorry, Zev, yeah.
Hi, everybody.
Hi.
Can you go to the next slide, please?
Sure.
So You know, some of the challenges we're facing in esophagogastric cancer have to do with a very rapidly changing landscape. We'll go over some of that, and we'll talk about the active studies that are open and the studies we're working hard to open that are in development. Next slide. So really in the last year, we've seen several new drug approvals, and that has made shifting landscapes challenging. As we all know, immunotherapy is now part of the landscape, and it's not universally recognized even which patients should get nivolumab upfront with chemotherapy. There's still controversy about CPS score and likely to continue to be controversy. So that makes control arms and studies especially challenging as we start to go through what new studies we should do. We've also seen 2 new drug approvals in the last year in HER2 positive disease, which include the Keynote-811 and allowing pembrolizumab upfront in patients with HER2 positive disease and patients in TDXD, which is a DSA201, the ADC, in second line and beyond HER2 positive gastric cancer. So the HER2 space got crowded too. So all in the context of trying to develop targeted approaches beyond what we already know. We expect that, as you just heard, adjuvant nivolumab got approved as well, and that got approved last year too, and that's made, for example, some of the challenges that Simon was just referring to with the ongoing study having to require amendments and holds on the protocols. Next slide. So the expectation is, in fact, this will get even more complicated in the next year as we start to wait for several large randomized phase 3 trials to look at subtyping of patients even more so. So as we start to develop new concepts for SWOG, we have to keep in mind that additional biomarkers which have been validated in randomized phase 2 studies are going to be either validated or not in randomized phase 3 trials, and that impacts how we design new studies. Not to mention the fact that one of the great things about having all this excitement in gastric cancer has led to a challenging situation, which is that we have a lot of competing industry interest now, which makes designing trials and finding centers without competing interests especially challenging. The one space, and this is where Anwar spoke about her trial this morning, the one space where we don't see a lot of interest or competition at the moment is second-line therapy. So we're trying to leverage what we already have that Anwar has built and try to push that in a second-line direction. Next slide. So I think we talked about some of the ongoing trials. This is a trial of Natalie Oboha with the SWOG champion David Horowitz, in which patients receive upfront chemotherapy in patients with and looking at the question of consolidated radiation therapy with low volume or oligometastatic disease, answering a question beyond, is there additional value to radiation in select patients? And actually this group of patients is actually increasing. So we do see more and more patients with oligometastatic disease. So answering an important question in the field, and the SWOG champion is David Horowitz. Next slide. The NRG GI-006 study is a randomized trial comparing different focuses of photon radiation for esophageal cancer, run by Steve Lin with the SWOG champion of David Jen, asking the question about differences about radiation. The study was activated in March exactly 3 years ago, and accrual is ongoing. Next slide. The Alliance study, which is planned, not yet activated, is going to look at the intensity of chemotherapy and upfront, just like in other cancers. We're proving that perhaps more is better upfront. So we're looking at the question of FOLFIRINOX, which is standard in colorectal to some extent, and pancreatic, and comparing it to FOLFOX, Nivo. And now that nivolumab is approved in all patients, it makes this trial eligibility-wise certainly easy to look at, and this trial is going to be looked at by Haesung Park in the Alliance and is not yet activated. Next slide. The trial that Anwar will hopefully be leading as we go through the final steps is actually, I think, a very important trial to look at second line, and one of the few trials both in the cooperative groups and in industry, to look at second-line patients with metastatic gastric cancer to try to improve on the current standard of care, which is paclitaxel ramucirumab. And, you know, trying to answer several questions in this trial and in the study design, which include the question of immunotherapy beyond FOLFOX/nivo. Is there a role for that? And can it be added? Can we substitute paclitaxel with VEGF-TKI, Cabo, that Anwar has done an investigator-initiated trial and presented some provocative early phase data. So hopefully that trial will ultimately open in SWOG in the next year, in 2022. Next slide. As we look beyond metastatic disease, we also look at opportunities in early stage, and there have been landscape changes in early stage disease, particularly with FLOT now becoming the standard of care. We're trying to, and Joe Chow is leading this one, and trying to push it through, trying to partner with HER2 inhibitors and IO. This is in development still, but really I think answers an important question, which is not been answered in the field and is not, to our knowledge, being addressed in other studies, which is resectable HER2 positive disease. Can we improve long-term survivorship in patients if we add targeted therapies blocking HER2 with or without immunotherapy? And it's as conceived, looking at event-free survival and pathological response rate. So the next year we think has opportunities, and in a changing landscape disease like gastric cancer, we had some ideas that were put on the shelf for a little while because all these drug approvals became available in 2021. It was a year of 3 or 4 new drug approvals, believe it or not, in gastroesophageal cancers. And that's a changing landscape, which makes it a little more challenging. Perioperative therapy, though, for now, we see an opportunity to, as mentioned, look at both total neoadjuvant therapy, perhaps trying to increase what we do up front, as has been the suggestion in other cancers. Working on incorporating ctDNA in all of these studies, which has become more in vogue now, certainly in esophagogastric cancers. Really looking for opportunities in second line, and even now perhaps in third line or refractory metastatic gastric cancer, where there's more and more patients certainly who are getting refractory therapy in third line setting, and an opportunity for improving outcomes exists as well. So next slide. And that's where we are for esophagogastric cancer.
Thank you very much, Zev. This is great. Any questions for? I
actually have 2 questions, one for Dr. Zen and one for Zev. Dave, you are the champion for the NRG photons versus proton study in esophageal. How is the study accruing, and what is the standard of care in terms of radiation therapy for these cancers?
Yeah, so I think it's been a challenging study to accrue to. I would say Dr. Lin, I believe coming from MD Anderson, they've been the highest accruing to this trial. I think, one, this has to be done at select centers that have proton beam. At University of Washington, Fred Hutch, we do have that. But I think the challenge is that there are a subset of patients that with Medicare, they actually can get proton therapy covered. And there's this whole kind of conception among patients that proton therapy is better from an efficacy standpoint, but there's really no data suggesting better efficacy. We actually more sell proton therapy as more of reducing long-term risk of complications. And so I think part of it is, as a team in our multi-D clinic, is being not biased towards that and trying to recognize that we don't really have any prospective data, and trying to, demonstrate equipoise to our patients that this is an important study that we need to conduct.
And how is SWOG doing with accrual?
SWOG's really poor, so I'm hoping to work on that. So, yeah.
Okay. Yep. And my other question was in second line gastroesophageal in this territory where we are developing new studies. How are we going to do translational research in that space? How easy is it to biopsy patients, and how ethical is it to biopsy patients to study the immune microenvironment?
Yeah, I think it's possible. And Gabby, you know that at our center, we've participated in a few studies that require on-treatment biopsies and that kind of thing. Obviously, some patients are not as willing, but it's definitely possible. But I think that's going to be important as we head into the neoadjuvant space, and we need, especially with checkpoint inhibitors, but understanding about what are the response and resistance mechanisms to those.
Okay, thank you very much. Thank you, Zev. Thank you, David, for the clarifications. Now we move into hepatobiliary cancers.
Okay, next slide, please. I'm presenting on behalf of my co-chair, Dr. Shroff and Dr. Ahmad.
Okay, here you go.
Next slide. So starting with biliary cancers, the current standard of care continues to be gemcitabine cisplatin based on the ABC-02 trial, which showed superiority to gemcitabine alone. However, recently, next slide. Next slide, please. The Topaz study was just presented at ASCO GI, which evaluated the addition of durvalumab to GemCis versus GemCis and placebo. And as you probably saw, this was a positive trial with improvement in survival, as shown on the next slide. You can see that the curve separated around 6 months, and that resulted in a survival improvement of 12.8 months with the combo versus 11.5, hazard ratio of 0.8. So it's a positive study. There is quite a bit of discussion as to whether there is a subgroup of patients that benefits the most. It may be mostly the intrahepatics. The study certainly was dominated with accrual from Asia. So some things will need to be sorted out over time, but certainly this is a welcome improvement and development in this disease. Next slide.
But at this time, there's no FDA approval. Are you using it as in your patients? Are you able
Not
to?
yet. Pending the FDA approval, yes, currently. Next slide. So there were other attempts to improve on GemCis. This is a study looking at modified FOLFIRINOX, which was negative, and it was intended to be a phase 2/3 study, and it was ended at the interim analysis. Next slide. And this brings me to our own SWOG study. But before that, give you some background. The study was based on this phase 2 data from Dr. Shroff when she was at MD Anderson. This was an MD Anderson Mayo study that looked at the triplet of gemcitabine, cisplatin, nab-paclitaxel, which showed a very promising PFS of 11.8 months, OS of 19 months, and a response rate of 45%. Some patients actually were converted to have resectable disease. So a promising signal, which led us to take this into the phase 3 setting. Next slide. In this SWOG 1815 study, which has completed accrual at this point since February of last year, looking at the triplet versus the control arm of gemcitabine cisplatin. We are looking forward to the final results coming out, hopefully as soon as possible. Don't have a time yet, but this is going to be the largest first-line biliary study to be conducted in the United States ever. And we're proud that SWOG was able to lead this study, and we're looking forward to the results. There were also tissue and blood collected on these patients, and a lot of biomarker work will be planned. Next slide. In second line, next slide. FOLFOX continues to be the standard of care based on ABC-06, which compared FOLFOX to active symptom control, but supportive care basically. And again, modest improvement here. Next slide. You can see the median OS of 6.2 months versus 5.3. Next slide. And you heard earlier about some of the molecular subsets that are gaining prominence. If you hit the button, it's gonna hit the slide one more time, please. I think it's an animated slide. Certainly the FGFR2 fusions, the IDH mutations, we now have approved agents for these. These are mostly in intrahepatic cholangio. And then for HER2, there are studies for HER2 positive, which are mostly gallbladder and extrahepatic. and other studies evolving in this space as well. Next slide. So what's going on in the NCTN? There is an alliance trial that's still evolving through the process, not fully approved yet, which is looking at second line FOLFOX plus binimetinib, plus minus binimetinib. It's a randomized phase 2 study. And this is going to be focused on patients with MAP kinase alterations. So RAS, RAF, MEK, ERK alterations in biliary tract cancer, which are mostly going to be patients with extrahepatic or gallbladder rather than intrahepatic. But certainly this is looking at the second line space to do better than FOLFOX and trying to enrich the population with specific alterations. The next slide. Some areas of focus for us within SWOG that we continue to do some work on are to evaluate the targeted therapies in the perioperative setting. We've had different concepts go back and forth. There are some feasibility concerns that we're working through there. Certainly, we are looking forward to the results of SWOG 1815 with the gemcitabine, cisplatin, and Abraxane combination. And if that is positive, that could form a backbone to build upon as well. And as I mentioned, we will be doing some of the biomarker work there. And we are certainly looking at other concepts in second line, including potentially a concept with Biliary as a backbone that Dr. Richard Kim may be leading in the future. We had some preliminary discussions about it at this meeting. Next slide. Moving all forward to HCC, next slide. So the combination of atezolizumab, bevacizumab has been the standard of care based on IMbrave 150 with a significant improvement over sorafenib. Next slide. Then recently we heard about Himalaya, which looked at the combination of one loading dose of tremelimumab with continuation of durvalumab single agent, known as the STRIDE regimen. This was shown to be superior to sorafenib as well, as shown here. Median OS of 16 months with the combo versus almost 14 with sorafenib, response rate of 20%, and an impressive 31% OS rate at 36 months. This is also not FDA approved yet, but will be reviewed this year. And this may become another non-VEGF containing option for advanced HCC. Next slide. The study also had another arm comparing durvalumab single agent to sorafenib. This was a non-inferiority comparison, and it was met. So durvalumab was non-inferior to sorafenib, also with a median OS of 16 months and a response rate of 17%. So very consistent with what was shown with other single agent checkpoint inhibitors in this disease. Next slide. At the NCTN level, the NRG-GI003 study is still open and accruing slowly. This is a study looking at patients with liver-limited disease that is multifocal. It's stratified by vascular invasion or not, and it's comparing protons to photons. So this is certainly limited by the centers which can participate, but it's continuing to accrue at a steady rate. And we hope to see it to conclusion. Next slide. These are the eligibility criteria for the study. They've been made as reasonable as possible. Of course, they're still limited to Child-Pugh-A, and there are some limitations on the size of tumors, but it's quite generous in that sense. Of course, some of these patients who have multifocal disease nowadays are tending to go straight to systemic therapy, may affect this protocol, and that's being discussed at the moment as well. Next slide. In SWOG, we have two concepts. The neoadjuvant study of Nivo-Ipi. I'm sorry, I guess, okay. Could you go back one slide again? Yeah, this study, RTOG-1112, actually has been close to accrual, and it accrued 193 out of the planned 292 patients. It struggled with accrual because the standard of care kept evolving as the study was being conducted. But it's really asking the question whether the addition of SBRT to systemic therapy improves the outcome of these patients. It was an important question, still is an important question. We hope to learn with the patients that have been recruited so far, and the accrual, the events are still ongoing, and we look forward to the results over time. Next slide. So in SWOG, we have two concepts in HCC. One is the neoadjuvant study of nivo-ipi in patients with resectable HCC, which we mentioned earlier, and a phase 2 study of durva-tremi in patients with Child-Pugh B cirrhosis. Next slide. So this study, the first study you already heard about, will be led by Dr. Kasab, looking at neoadjuvant nivo-ipi. This study will be led by Dr. Arora, and we'll be looking at the STRIDE regimen. So one loading dose of tremi and with continuation of durvalumab, because this regimen has a favorable safety profile. And we would like to explore its safety and preliminary efficacy in Child-Pugh B 7 and 8 patients. So this is looking at this area of unmet need where we have safety data now for nivolumab single agent from Checkmate 040. And there is some limited data from sorafenib. But certainly these patients represent a significant proportion of the patients that we see and do not have a definitive standard of care. So this will be the first study to evaluate combination therapy in Child-Pugh B with a primary endpoint of response rate. We will plan to recruit 58 patients, and the criteria have been carefully selected to balance safety and accrual. And they mirror the criteria for Checkmate 040 nivolumab Child-Pugh B cohort, so we can have adequate historical comparison. And I won't go through these in details. They are shown here on the slide. That's it. Any questions?
Thank you. So we go next.
Next, we'll have the neuroendocrine committee. Eloisa.
Thank you again for giving the opportunity to discuss NET studies. I'm presenting this on behalf of Dr. John Strasberg and Arvind Desai, who actually lead the NET subcommittee. So last year, well, between 2020 and 2021, we had the clinical trials planning committee for neuroendocrine tumors to address how to develop neuroendocrine tumor trials in the era of PRRT. And about 8 concepts have came out from that meeting. And the one that is almost ready for prime time has been already approved by the GI steering committee. This is the one that you see here. That's in regards to the retreatment of patients with PRRT. So patients that have here a well-differentiated midgut neuroendocrine tumor that has received PRRT and had a durable response of at least 12 months will be eligible at the time of progression to receive retreatment with lutetium-177, and they will receive up to 2 treatments. This is going to be a 2-to-1 randomization, and patients will be randomized to retreatment with the PRRT or to receive everolimus. This study is a collaboration between the Canadian cooperative group led by Simran Singh, and we have our own Aman Shaman from SWOG being the co-study chair. The primary endpoint is disease-free survival, and the total number of patients that are expected to be accrued is 126 patients. So as I mentioned, that has been approved by the GI steering committee. The protocol is being written right now, and I'm hopeful that in the next 9 to 12 months, we will have this study open for activation in many centers. From the CTAP, from the clinical trials planning committee, we also, I mentioned these are 8 proposals. There are 4 subgroups that are meeting on regular basis to discuss other concepts, and they include concepts of incorporating immunotherapy to PRRT, or what's the best option for patients that have a liver dominant disease, PRRT versus liver embolization, or both together. There's also the role of radiosensitizers with PRRT, and the role of stereotactic radiation in addition to PRRT. They all have been in study, and we have representation on SWOG in all these working groups. So ongoing trials, we have the cabinet trial, and our study champion is Dr. Strasberg. This trial pick up some speed in terms of accrual after they allow for crossover. This is a study that patients with well-differentiated GI nets, or actually unknown primary, even lung, well-differentiated nets, are randomized on a 2-to-1 fashion to receive cabozantinib versus placebo. But if and it's a blinded study, but at the time of progression, the patients are unblinded, and if they are on placebo, they're allowed to then cross over and receive cabozantinib. The primary endpoint is progression-free survival. And you can see here the details in terms of eligibility. So it's halfway through, but there's still plenty of time to open at your center if you don't have that study yet. And this is third line. So if patients progress on somatostatin analog, a second FDA-approved medication or treatment, then as a third line, they can be enrolling on the cabinet study. This is also an important trial for a rare disease that about the use of temozolomide and loratadine versus temozolomide by itself in patients that have advanced progressive paraganglioma on pheochromocytomas. This is a study led by Alliance, and Dr. Charles Lopez is our champion. The trial was activated late last year and is slowly accruing. I believe now they have 5 patients so far that have been enrolled in the study. Obviously, it's a rare disease, so we really need the contribution of all the centers to open this study or refer to a center that has this study. Okay, this is another Alliance study that we have our own Andrew Hendefar as the SWOG champion, is to use PRT with lutetium-177 in bronchial or thoracic well-differentiated neuroendocrine tumors. And in this study, patients are randomized to lutetium-177 versus everolimus, which is FDA-approved treatment for bronchial lung nets. I believe that the study was just activated as well late last year, so we haven't seen any enrollments quite yet because everybody is still opening the study on their sites. Finally, we have this Alliance study that's a collaboration with SWOG. That's to understand what's the best treatment for patients that can receive either lutetium-177 or capecitabine. This is for patients with well-differentiated metastatic progressive pancreatic neuroendocrine tumors. And then many times in clinic, we debate, should we go with PRT or should we go with CAP10? Well, this study hopefully is going to help to answer the question. This study led by Tim Hopday, and I am the co-chair SWOG champion for the study. It's actually just got activated about 2 weeks ago, so please let your CTO office to know and consider opening at your site. And finally, just to mention, this study has been closed, and hopefully we'll have results discussed during the ASCO meeting. This is to understand what's the best treatment strategy for patients that have high-grade neuroendocrine well-differentiated tumors or poorly differentiated neuroendocrine carcinomas that are metastatic. And this study, when it was enrolling, was to randomize patients to platinum and topazide versus CAP10. After some revisions, the study design was changed to close after 80 patients, and results were sent to ASCO. Hopefully we'll learn what the study shows in June. In terms of ongoing trials, this is a super exciting time for the treatment of neuroendocrine neoplasms, and it's also a very nice community, so I encourage everybody to participate. We have the NETTER-2 study that is looking at the role of PRT in patients that have grade 2 and grade 3 well-differentiated GAP nets. We have the COMPETE, which is looking at Edotridine versus everolimus in patients with GAP nets that are well-differentiated in G1 and G2. We have the RETNet trial to try to understand what's the best way to treat liver-dominant disease, whether with blend embolization versus chemoembolization. We have a first-line trial looking at a different composition of octreotide, which is done now subcutaneous, and it's a pharma sponsored study. And we have the Action 1 study that's actually looking at a different PRT technique using actinium-225, which is an alpha emitter. And this study is going to look at retreating patients that progress elution with then actinium-225. And it hasn't been activated yet.
Thank you very much, Ariza. And any questions to Dr. Suarez? If none, then we invite Dr. Anrulawi to present on behalf of the subcommittee on pancreatic cancer.
Hi, I'm going to present on behalf of Devendra Sohal, my co-chair. Really just have a couple of things to run through because we already alluded to a lot of the ongoing activity in pancreas. Yeah. So this is the last NCTN trial that's open that I think we haven't discussed today. This is the GIANT trial being led by Efrat Dotan. This is a study in patients with stage 4 disease. It's really designed to look at a subset of our patients, which represents a very important subset that has not been studied independently, and that is the elderly or frail patients subgroup. And it's a randomized study looking at a modified schedule of gemcitabine nab-paclitaxel versus Biliary. This is accrued about 75 patients out of a target of 184. So it is accruing, but certainly we would like to increase accrual. David Zen is our SWOG champion, and so I don't know if you had anything to add about this study, David.
Yeah, I actually spoke to Dr. Dotan recently, and so she tried to actually made an addendum to do a Fitbit to look at functional status. The NCI declined that, but she is in the middle of putting in a protocol amendment to hopefully clarify some language about eligibility. All these patients have to go through a geriatric scale, which is a little bit cumbersome. That's what the NCI wanted, but she's hoping the updated language will help with that. So
great, thank you. So now I'm going to just mention 2 trials that are in development by SWOG. The further along is S2211 that's being led by Greg Botta from UC San Diego. And this is a study looking at the tumor penetrating peptide SEND1 or IRGD, whose purported mechanism of action is to increase drug delivery into pancreas cancer. The schema here that was initially presented included a combination with gem-nab-paclitaxel. Because there's a study with a similar design that is about to open in Australia, the GI steering committee suggested, and we agreed to change the backbone to FOLFIRINOX. And so that's going to be represented to the GI steering committee shortly. And so this will be a phase 2/3 design, with PFS being the endpoint for the phase 2 portion, and then OS if it goes on to phase 3 if it passes the bar. Any questions about this study? So hopefully we'll be hearing about approval before too long. And so this is a study that Devendra Sohal has been leading and working on for quite a long time now, that we're hoping to finally get moving forward with. This is a platform designed for patients with resectable or borderline resectable pancreas cancer. And the concept is to have a trial that we can keep open and sequentially add novel agents to as they are developed and show interesting preliminary activity. And so it's a rolling platform with, again, a phase 2, phase 3 design. And the study, we hope, will start with the first novel agent being a CXCR4 inhibitor based on work in the laboratory by Venu Pilasaretti, a surgical oncologist at the University of Washington. We have endorsement from the company to proceed with that agent plus checkpoint inhibition. And then we have a few other agents that are in initial conversations as listed here, including a RAF/MEK clamp inhibitor, and there have been other agents that have been discussed. So we really needed an initial agent that we have available for us to move forward with this to present to GI steering, and we're just about there. And this is Venu, and again the agent that we're intending to get started on with this concept. And so this just shows you the design. It'll be a FOLFIRINOX backbone plus the experimental agent BL-8040 plus pembrolizumab, and there'll be a rolling control arm along with this, and then obviously hopefully additional arms as well. So hopefully you'll hear more about this in the near future. Any other questions?
Any questions?
I wanted to just make a comment to support the elderly frail adults study. There was a recent paper showing that treatment of elderly frail adults with gemcitabine nab-paclitaxel was associated with detrimental effects versus gemcitabine alone. So I don't think we should be shy in pushing our elderly and frail patients to roll on to doublet and triplet chemotherapies when we can be gentle and potentially the outcomes could be superior. So I just am fully supportive of the GIANT study.
Just do this.
Okay. Okay. Messed it up. There we go. Thanks. Good afternoon. I'm presenting on behalf of my two co-chairs who I'd like to introduce. There's been some changes in the colon committee. Wells Messersmith has stepped down, having gone on to other responsibilities, helping to manage his cancer center in Colorado. So Marwan Faki, medical oncologist from City of Hope, with phenomenal expertise in management of colon cancer, has joined us as a medical oncology co-chair. And we're extremely fortunate to have Sep Galami from UC Davis, a surgical oncologist, to be our surgical liaison co-chair. She's an incredibly experienced surgical oncologist and going to bring great vision to the development of our trials. So we're going to start out with recent highlights, and I'm going to turn it over to Dr. Faki.
Thank you, Phil. All right. Thank you, everybody. So what I wanted to go over today is just a little bit highlights as to what we've learned at this GI ASCO. And the point being here is their role for immunotherapy in microsatellite stable colorectal cancer. So there has been many posters, and I think the take-home message from this GI ASCO is that there is activity, but there's a lot of heterogeneity. And what we're missing is really a good biomarker as to who is the patient with microsatellite stability that could respond to checkpoint inhibitors, among other immunotherapy agents. So what you see on this table is a summary of three studies that were presented this GI ASCO. And you can see that combinations of PD-1 inhibitors plus MEK inhibitors plus bevacizumab had a response rate of 13%, disease control 74% on this study. Others have looked at VEGF inhibitors, angiotensin II plus a PD-1 inhibitor. Again, low response rate 7%, disease control rate 57%. Dr. Saeed presented the cabozantinib durvalumab study, PD-L1 plus cabozantinib, and you can see a response rate of 27.5% in evaluable patients if we count the whole population, and if we look at confirmed responses, 16%. But if you look at the subpopulation and biomarkers, we still don't know who are the patients who benefit the most. It's interesting on the cabozantinib studies that there had been a better response rate in the RAS wild type population. You can see an overall response rate of 50% in the MSS RAS wild type, disease control rate of 80%, but we're talking only about 12 patients evaluable with RAS wild type, and certainly better PFS here and overall survival, minimal activity in the RAS mutant population. On the other hand, a combination of cabozantinib plus atezo, 31 patients had a response rate of 10%. And again, similar signal here, 25% response rate in the RAS wild type, a PFS of 5.8 months in the RAS wild type. Dr. Barzi presented regorafenib plus pembrolizumab, and similar findings to what we have seen on Rego-Nivo. in that the benefits were mostly seen in patients with non-liver metastatic disease. If you look at liver metastases, PFS 1.8 months. And if you look at non-liver PFS is 4.3 months, which is really exactly what we have seen on REGO-NIVO 70 patient trial, where we have seen a PFS of about 3.5 months in non-liver metastases, PFS of 2 months with liver mets, and response rate 21% in the non-liver metastases. We have reported this GI ASCO on the biopsies from this study, and what we have seen is that the patient who responded to treatment had an inflamed profile, so they had a higher CD8 expression in the tumor, higher interferon signature, et cetera. And those appear to be more likely not to be liver metastases in that setting. So there's a biological reason for that discordance. Others have looked at combinations of PD-1 plus LAG-3 inhibitors. This is a study of 80 patients. And interestingly, there's a correlation here between PD-L1 expression and response. And I think this is being evaluated further in larger trials to see if the PD-L1 expression is associated with higher chance of response to PD-1 plus LAG-3 inhibitors. And Dr. Morris presented his data earlier and rationale. So finally, one other reason I think that there could be a signal for microsatellite stability as far as response to PD-L1 is the data presented by Dr. Heinz Lenz as an oral presentation at GI ASCO, which showed that if you add nivolumab to FOLFOX bevacizumab in patients with metastatic colorectal cancer or MSS, the response rate goes from 46% to 60%. Now, even though the median PFS did not change, even though the median OS did not change, but the overall survival continues to be evaluated, and most patients have not, about more than 40% of patients have not died yet on this study. You can see that as you follow these patients up further, there is definitely a signal. At 15 months, 21% of patients on FOLFOX had not progressed versus 45% with FOLFOX bev nivolumab. And at 18 months, 9% had not progressed with FOLFOX bev versus 28% with FOLFOX bev nivolumab. So we still don't know what is the biomarker. We think that definitely the metastatic disease site has something to do with it, but it's more complicated than that. That's enough rationale. This is a rationale why we should continue to look further in this population, but we need to find a better biomarker. So we can move now maybe to the active SWOG and CTN studies. We're giving summaries, right? Okay. Okay, so if anyone, I think I can go over this. I don't think Raghav is here, but SWOG 1613 is now close to accrual. This is a randomized phase 2 study to see if HER2 amplified patients who receive trastuzumab pertuzumab do better than patients who receive irinotecan plus cetuximab, with the primary endpoint being PFS. The enrollment on the study was a little bit of a challenge, and the study was redesigned for the PFS endpoint and response rate endpoint, and now it's close to enrollment. The patients who were HER2 amplified on the study who were evaluated were 69. Those who were treated and randomized were 54. We still believe we're going to get some valuable data, but it's not as powered as it was supposed to be initially. So Dr. Overman is the PI on SWOG 1922. And if there's no representative, I can present this as well. This is a randomized phase 2 trial with ramucirumab paclitaxel versus FOLFIRI. Again, there's no good options for patients in the second line for small bowel cancer, and we do not know what is the best treatment for those patients. The study is looking at one-to-one randomization, and 20 patients have been enrolled so far on this study, looking at progression-free survival as an endpoint. SWOG 1610, NRG 1004. This is This is a COMET trial randomizing patients to receiving FOLFOX Bev versus Atezo versus FOLFOX Bez Atezo. The FOLFOX Bev arm was closed in light of the data from the Keynote 177. The study has therefore been re-amended as far as stats, with the total number of patients now 211, given the fact there's only 2 arms, and 84 patients have been enrolled so far. So we certainly need help on this study. Dr. Jason Zell. Jason, are you on? This is Dr. Zell's study, the PACES trial, preventing adenomas of the colon with eflornithine and sulindac. This study is getting closer to accrual. It's looking at patients with history of colon polyps and assessing prevention of recurrence of polyps within 3 years of high-risk polyps. The study had been amended to have only 2 arms of treatment, eflornithine plus sulindac versus double placebo. There's only 57 more patients to go to the goal of enrollment, which is 389 patients. So getting closer there. All right.
Oh, here you go. I'll just sneak up on you.
Thank you for saying
that. This is the ATOMIC study. This is for stage 3 MSI high colon cancer. Patients are randomized to receive FOLFOX Atezo versus FOLFOX alone. What's kind of interesting about this study is that there's now a collaboration with AIO, which is going to help accrual. But the target accrual is 700. The total accrual, as actually of last month in March, was actually 575. Looking at accruing about 14 or 15 per month, 55 credits are assigned to SWOG. So, keep looking. These are not easy patients to find, but when you do find them, I think this will likely be a practice-changing clinical trial. Also want to give you, this is really sensitive, want to give you an update on Circulate US. This is for lower risk stage 3 colon cancer. This is a ctDNA directed study, and it is finally open. It only took about a year. So this is for T1 through 3 or N1 stage 3 colon cancer. And ctDNA is tested using the Signatera assay. If they're ctDNA negative, they get randomized to standard of care chemotherapy versus observation with serial ctDNA testing. If you do turn ctDNA positive, then you get randomized into the second arm. So ctDNA is detected either postoperatively or anytime during the serial testing period. Patients are randomized to receive standard of care chemotherapy versus escalation chemotherapy with FOLFIRINOX. I won't go through all of this, but essentially this is a disease-free survival endpoint for the phase 3 portion. This is now open, so please think about considering opening it at your site and enrolling patients. Great. And then Cobra. Van, are you on for Cobra?
Thanks, Chris. Yeah, so this is the NRG GI005 trial. This is led by Dr. Aaron Scott. He's the SWOG champion for this study. I think he's on a flight back home now. But this is a phase 2, phase 3 trial looking at circulating tumor DNA as a predicted biomarker for patients with low risk stage 2A colon cancer. So these are patients that, based on current practices, surgeons and medical oncologists would feel would not need adjuvant chemotherapy under standard practices, and patients are randomized in a 1-to-1 fashion to either active surveillance with close follow-up with CT scans every 6 months, or to an assay-directed therapy arm where, if they are ctDNA positive, they would go on to receive 6 months of adjuvant chemotherapy with a fluoropyrimidine oxaliplatin combination. If prospectively found to be not have detectable circulating tumor DNA, they would proceed to active surveillance. We're using the Guardant Reveal assay, which includes both somatic mutations and methylation profiling for the selected assay. As you can see here, we're about 275 patients into this study. So appreciate continued participation if possible in the study.
I just have one slide. This is the Solaris study. This is an ATOMIC study that is randomizing patients in first-line metastatic colorectal cancer to FOLFOX. and bevacizumab with vitamin D, or just FOLFOX and bevacizumab. It's enrolling quite well. We are at, I think, 334 patients and 20 to SWOG as of the last count, but we're still just trying to do this final push. So for those of you that have it open, please continue to accrue. Thanks.
Thanks, Marwan, for rolling down the studies. What was the last slide? There it is. Briefly, just want to touch upon some of the concepts that we're working on. Some of these are further along than others. Many of them are highlighting some of the things that Dr. Faki just mentioned about valuing the further role of immunotherapy in patients with colon cancer. Doctors Krishnamurthy and Senthil are working on a neoadjuvant chemoimmunotherapy regimen for patients with high-risk microsatellite stable colon cancer. That's in development. Sorry about the numbering kerfuffle there. Dr. Cohn, who is just up here on the podium, is developing a high-risk stage 3 colon cancer study of immunotherapy, but this is for patients who have evidence of microsatellite instability or deficient mismatch repair, and that's in development. Drs. Patel and Dineen are working on a HIPEC cytoreductive surgery and a HIPEC study for patients with high-grade appendiceal cancers that will be done on a limited institution basis. And Dr. Faki, who's just up here, has a study that's been to the colon task force and is now in further development, looking at the combination of regorafenib, ipilimumab, and nivolumab versus regorafenib and nivolumab alone in patients with microsatellite stable chemotherapy-resistant colon cancer. He's got some pretty compelling evidence about the activity of this regimen in patients with predominantly lung metastasis, but really just non-hepatic metastasis. Dr. Liu, who is just up here, we already talked about Circulate, we can skip that. There are 2 studies that are opening within the task force, within the GI steering committee mechanism. One is the Eraser trial that's just recently opened. Dr. Galami is the SWOG representative for that study, and we'll present that in more detail at the next meeting. But that's an ablative study where patients with metastatic disease are going to have combinations of radiation therapy and ablation to try to render them free of disease. And finally, there's an adjuvant BRAF study in development, recently approved by the GI steering committee by Dr. Yeager, and we will need to eventually assign a SWOG champion for that study. So that just gives you an idea of where the committee is heading with a real focus on the further integration of immunotherapy in the management of patients with advanced disease and advanced locally aggressive locally advanced disease as well. Thank you for your attention.
Thank you. Wait. Any questions for Phil? Thank you. You explained everything. And again, thank you for all the members of the subcommittee who did a great job. Now we have at least you're going to do. So Dr. Kachnik is going to do the rectal anal subcommittee.
And I'm presenting on behalf of my co-chair, Dr. Hagen Kennecke, who just had a baby, even though he was trying to come, but I told him I had it. So these are recently closed and ongoing trials. I'll show you the ongoing trials, but just to give you sort of a task force update, the locally advanced anal trial, ECOG 2165, has now fully accrued. And to remind everyone, chemoradiation standard, and then randomized to adjuvant Nivo or not. So these are the almost closed trial. I don't know, is Dr. Sun on? Well, you probably heard it from plenary too, but this is SWOG 1820. It's actually looking at trying to minimize bowel dysfunction for rectal cancer survivors. And I just want to thank everyone because we just found out today and at plenary, it is sort of the first step of it's fully accrued. So thank you. I have to change the previous slide now. So I don't know, May, do you want to comment? Are you here? Or I'm certainly happy to. I don't see her, so she was here earlier. So this is EA 2201. It's a phase 2 study looking at neoadjuvant Nivo plus IPI and short course radiation for MSI high rectal tumors. These are CT3 to 4, NX or node positive patients. They get 2 cycles of IPI and Nivo. They then get short course radiation over a week, and then 2 further cycles of IPI Nivo and a single arm phase 2 2-stage design. And then they get reassessed for surgery and then TME. Dr. Sambor is a PI, and as I mentioned, Mei Cho is our SWOG champion. The primary endpoint's an increase in PCR rate. There's some important amendments coming up, but I wanted to encourage folks to accrue. It's opened a few months ago, but we need your help. There will be an amendment that's coming to actually move the 4 cycles of Nivo and IPI up front and then do the short course. And then there's ongoing discussions with Foundation Medicine regarding adding ctDNA. So for anal cancer, Jim Murphy, are you on? Okay, this is EA 2182. This is the decreased trial. Now this is for actually early stage anal cancer, the T1, smaller T2 and zeros. And if you have that as assessed by PET CT and or pelvic CT MRI, you could go on this randomized phase 2 trial looking at standard dose chemoradiation versus a little bit decrease in radiation dose and only 1 cycle of 5-FU and mitomycin. So this trial is actually accruing fairly well. The lead investigators, Jenny Dorth, I mentioned, our SWOG champion, and the primary endpoints, 2-year disease control. So I think, so we have some time for a patient advocate. Should I just mention the concepts and not go through them in detail? Okay, perfect. So the first one is a concept, since I just showed you that the locally advanced anal with the adjuvant Nivo closed, we now have an opportunity to seize so that we can sort of start looking at the next locally advanced anal trial here at SWOG. And Dr. Horwitz and Dr. Cho are looking at a doublet immuno phase 2 concept with an early primary endpoint of 3-month clinical complete response. It was presented this morning. It was favorable, so we'll develop this and hopefully move it forth and show you more of it at the next meeting. Similarly, we have from Dr. Kennecke and then a surgeon, Carl Brown from Canada, a stage 1 rectal concept. It's actually looking at, and again, a randomized phase 2 design, chemotherapy, and then organ preservation with local excision versus chemotherapy, and then potentially chemoradiation for organ preservation. Their primary endpoint's 3-year organ sparing, and this one will be a Canadian trial, but with a SWOG co-PI, which is obviously our own Dr. Kennecke. And then the Janus trial was just approved. This is for stage 2 and 3 rectal cancer. It's sort of our first intergroup attempt for a watchful waiting approach. It's a randomized phase 2 design looking at standard FOLFOX versus FOLFOXIRI. It's actually started with long course radiation and then chemotherapy. And then the primary endpoints, clinical complete response rate at 8 to 12 weeks post the TNT. This one actually is now pending approval at the steering committee. So we'll talk a little bit more at our next meeting because hopefully it'll be close to opening by then. And the last new concept is you just saw Dr. Stacy Cohen up here.
for the vitamin D trial is in earlier stage rectal cancer. And it's actually looking at if we can sort of adapt our treatment based on ctDNA clearance. And then again, we'll give you more of that at our next meeting. That was quick, but I did want to give time for patient advocacy at the end. Any questions?
Well, thank you. This was maybe quick, but it was fairly comprehensive. Thank you very much. Thank you.
I would love to introduce our patient advocate, Carol Siegel. We would love to have you here on stage and your colleague and talk to us about the involvement and how much is needed of the patient advocates in what we do here. Thank you.
Improving diversity and representation of clinical trial participants is the new initiative at SWOG. I am pleased to introduce Colmar Figueroa Mosley, our new diversity, equity, and inclusion champion for the GI committee. Colmar, yes, good. Colmar will be key to developing the methodology for the rollout of the next step, which will be to design the practical, real-time means of reaching that goal. Some of the questions that to pose are, how do we shift the culture from accrual as accrual to valuing representative accrual? What are the key drivers of diversity and inclusion on trials over which we have control, such as site selection, eligibility criteria, burden on patients, educating patients, and so forth? Who plays what role in optimizing diversity? How should targets be established? Should accrual reflect disease distribution? How do we plan for diversity and inclusion? Site selection, FDA guidelines, that sort of thing. How eligibility criteria impact diversity and inclusion? Example, hypertension in the African American community. How and when do we monitor and report diversity? How do we impact diversity mid-process? How and when do we share the results with the diverse population? The guiding principles need to be accountability, improvement, sustainability, intentionality, and measurement. We need structure to accomplish this, which includes collaboration with the statisticians, interim analysis, adaptive clinical trial design. This is a big effort with a huge benefit to science and mankind. We welcome Colmar to make this happen with us. Thank you.
Thank you.
You want to say something?
I'd like to.
They make you say something at the end of the day. I had the pleasure of actually sitting in the working group meeting, and so maybe off site or when we have our next GI meeting, discussing some of my observations, especially I have a background in study design, epidemiology, biostats. So there are some things that I've been thinking about, and I've been in consultation with Dr. Guthrie. So in terms of us addressing these issues around diversity, and sometimes we have to look at how we are designing the studies, and everyone hates to amend studies, but when they are amended, they can cause issues of power. And sometimes when you redirect a study, that might end up not making the currently enrolling study very efficacious. So it's some things for people to think about within the smaller GI steering committee, group meeting, but those are the beginning things that I may have some suggestions on how you guys can improve that. I come with over 25 years of experience. I spent a lot of time at Mayo Clinic and University of Rochester helping them with their studies and got them on track, which has got them a lot of funding. So, you know, I have that kind of experience from several institutions in improving their diversity, equity, and inclusion, and helping them steer to better ways of looking at these issues, especially when certain GI issues have a disparate amount of health disparities within the conditions that we're looking at, yet disparities was not mentioned at all today during the meeting. Thank you.
Okay, so this concludes our meeting in terms of information, and any questions, any comments you have on what we have provided you with, update on studies and also future plans. If not, enjoy the evening, and we'll see you in 6 months in Chicago.